A very good evening and namaste to all the respected viewers of today's CCI webinar. Our series launched by our respected Dr. N.H. Krishna sir and nurtured by Narayan Pradeep sir, Atri sir, a lot of others like Dr. Shivani Swami, Dr. Kirat, Dr. CVK sir, who is the backbone of all the academic content. Today, as a part of the ARDS webinar series that CCI is conducting, we are glad to have the second program and be a part of it with a very, very special group of faculty spanning all across India. Today, we will be discussing on the clinical management of ARDS and particularly the recruitment and ventilator settings. That means when you put a patient actually on the ventilator for ARDS, how are you going to manage him? The ventilatory part, the non-ventilatory part will be the crux of today's discussion, which is a very, very important topic for which we have a very august panel from Yashoda Malakpet, Hyderabad. We have the ICU in charge, the chief intensivist, Dr. Kaladhar sir. Welcome, sir, to the webinar. From Delhi, we have our senior CCI Life member who is also a third year DM. She is going to appear for her exam, so theoretically she will be most correct. I welcome Dr. Stuti Gupta, who is currently at Safdarjung. Then from the east, we have Dr. Pranay Vinod, who works at Ruben Hospital, who is the consultant pulmonologist over there, a very dynamic and budding young chest physician. And from Bareilly, the really Bareilly ki barfi wali Bareilly, we have Dr. Vivek Gupta, who runs his own hospital by the name, a very, very special name, which is Jeevan Dan Hospital. I really liked the name. Now, without taking up a lot of time, I would like to call upon Dr. Vivek Gupta, a young budding pulmonologist, to come and give his presentation on recruitment maneuvers. We have two presentations. The first will be by Dr. Vivek Gupta, followed by Dr. Kaladhar on the management of ARDS, followed by our panel discussion. So now coming on with Dr. Vivek Gupta.
Good evening to all. I'm Dr. Vivek Gupta, consultant pulmonologist in practicing Bareilly. Today I'm presenting a topic of recruitment maneuver in ARDS. First of all, I will thanks to CCI members, especially Dr. H. N. Krishna sir, Dr. Atri sir, and Dr. Ravi Dosi sir to give me this opportunity on this platform. Now, recruitment maneuver in ARDS. First of all, what is Berlin definition? Berlin definition in ARDS is defined as a syndrome characterized by onset within 1 week of unknown clinical insult, bilateral radiographic opacities not fully explained by proliffusion, atelectasis, and or nodule, respiratory failure not fully explained by cardiac failure or fluid overload, poor systemic oxygenation with PO2 FiO2 less than 300 and a PEEP or CPAP more than 5 centimeter of water. PO2 FiO2 less than 300 but more than 200 are preferred as a having mild ARDS. Moderate ARDS is defined as PO2 FiO2 less than 200 but more than 100, and severe ARDS is defined as a PO2 and FiO2 less than 100. Now, what is recruitment maneuver? Recruitment maneuver is a dynamic process of opening previously collapsed lung unit by increasing transpulmonary pressure. This maneuver is expected to improve oxygenation, lung compliance, and facilitate alveolar clearance, fluid clearance, and outcome. Alveolar recruitment maneuver is the intervention of intentional transient application of high transpulmonary pressure to achieve reopening of non-irritated collapsed peripheral airway and alveoli. Mortality benefits are controversial. Randomized controlled trial alveolar recruitment for ARDS shows these maneuvers are harmful and lead to increased mortality. Atelectasis results from increased interstitial pressure and weight of the lung. It can be enhanced by patient-related factors such as obesity, increased intra-abdominal pressure, high level of inspired oxygen in unstable alveoli, patient disconnection from the ventilation, and tracheal suctioning. This is a mechanism of lung during tidal ventilation. The uppermost part, upper base is inflated lung, middle part is small airway collapse, and lower base is alveolar collapse. A is stand for at end inspiration, patient alveoli may become overstretched. B is the excessive stretch may be generated at the boundary between aerated and non-aerated lung. And C is the dependent alveoli may be repeatedly opened and closed, producing tissue damage. Lung pathology in ARDS is not uniform. CT chest of this patient in supine position shows three different lung area with variable involvement. The most dorsal dependent area shows significant collapse due to interstitial and alveolar edema. This aggravates lung injury during mechanical ventilation by decreasing the size of the lung available for ventilation gas exchange. The most ventral region in the normal open lung which get overinflated causing volutroma and barotrauma. The area at the interface between the normal opening open lung and the atelectic lung is partially collapsed and is subjected to the shear stress by cyclical tidal recruitment and derecruitment. This is a mechanism of decruitment in ARDS. ARDS is an increase in intravascular lung compliance, increased weight of the lung, which can lead to collapse of alveoli and dependent portion of the lung. So if there is a certain decrease and collapse of disease alveoli. Then ARDS also get the heterogeneous process, selective distribution of tidal volume to normal alveoli, which can lead to decrease of disease alveoli and de-recruitment. These are functional recruitment first shows before recruitment and then another shows after recruitment. There is a alveolar irradiation, no vessel compromise, fluid, normal inflation, PO2 FiO2 increases, decrease PO2 and increase lung compliance. Lung protective mechanical ventilation. The goal of lung protective ventilation are to avoid injury due to overexpansion of alveoli during inspiration, that is voluntoma, and injury due to repetitive opening and closing of alveoli during inspiration and expiration, atelectic trauma. The injury can be prevented by application of sufficient PEEP mechanical ventilation using limited tidal volume. This slide shows the ventilation mode, volume assisted control mode, tidal volume was 6 ml less than 6 ml per kg predicted body weight. Plateau pressure was less than 30 centimeter. Ventilator set rate pH goal was 6 to 35, adjusted to the achieve tidal volume. Inspirative flow rate, I ratio adjusted to achieve I ratio 1 is to 1 or 1 is to 3. Oxygenation goal was 55% PO2 less than PO2 at less than 80 mmHg or 88 less than SPO2 or less than 95 SPO2. FiO2 peak. This is an FiO2 and peak incremented. When there is FiO2 0.3%, there is a peak of 5%, 0.45, 0.4, 8 peak, 0.5, 8 peak, 0.5, 10 peak, and 0.6, 10 or 0.7, 10. Further increment of peak to 30 centimeter of water allowed but not required. 10 to bean by required. Recruitment maneuver. These are four type of recruitment maneuver. Recruitment maneuver, sustained inflation, extended sink, and prone ventilation. What is sink recruitment maneuver? Consists of high tidal volume in control mode or high peak up to specific plateau pressure level for a selected number of cycles. Pelosi et al. 3 consecutive sinks per minute at 45 centimeter water. Plateau pressure found improvement in oxygenation, lung elasticity, and functional residual capacity compared to patient who did not receive sink. Mortality benefit was not observed. Sustained inflation recruitment maneuver. Most widely used recruitment maneuver. Ventilation is set in CPAP mode and then CPAP of 30 to 40 centimeter of water is applied for 30 to 40 seconds. Grosso et al. Reported improvement in oxygenation and lung function minimized atelectic in experimental clinical scenario. Also been associated with risk of hypotension, barotrauma. Done after ensuring that systolic blood pressure between 100 to 200 mmHg or heart rate between 70 to 140 per minute. Ensure patient is sedated and paralyzed. If FiO2 less than 1, FiO2 to be raised to 1 for 5 minutes. Ventilation mode to be changed to CPAP, the most recent PEEP level. CPAP to be increased over 10 seconds for 40 centimeter of water. CPAP to be maintained at 40 centimeter of water for 45 seconds. The recurrent maneuver can be terminated immediately and CPAP return to the most recent PEEP level if any of the following sign of distress occur. Systolic blood pressure to be 90 mmHg or by more than 30 mmHg. Heart rate increased to 140 per minute or by more than 20 per minute. SpO2 decreased by 5% or is less than 90%. After 45 seconds, at CPAP 40 centimeter of water, CPAP to be decreased over 5 seconds to the pre-recruitment maneuver level. Step-by recruitment maneuver. What are the steps is there? airway pressure and PEEP is increased for a specific time, this process gradually increases transpulmonary pressure and time for recruitment. Use stable peak and inspiratory pressure and incremental peak using a fixed driving pressure like 15 centimeter and step by increase in peak 25, 30, 35 centimeter of water for 2 minutes. Apply fixed tidal volume and step by increase in peak. Prone ventilation. Prone ventilation, prone positioning improve gas exchange via its effect on pleural pressure and lung compression. Increased functional residual capacity has also been proposed, but change in FRC has not been dominant finding in the most study of the prone ventilation. In supine position, the dorsal pleural pressure is greater than ventral pleural pressure. So the ventral transpulmonary pressure exceeded the dorsal transpulmonary pressure and greater expansion of the ventral alveoli than the dorsal alveoli. The result is a tendency towards overinflation of the ventral alveoli and atelectasis of the dorsal alveoli. Prone positioning reduces the difference between the dorsal and ventral pleural pressure, making ventilation more homogeneous, leading to the decrease in alveoli overinflation and alveolar collapse. Minimize stress and strain on alveoli, limiting ventilator-associated lung injury from overdistension cyclic atelectasis. What is compression? In supine position, heart compress the medial posterior lung parenchyma and the diaphragm compromise the posterior caudal lung parenchyma. Com- Compression by either the heart or the diaphragm may exaggerate dependent lung collapse in the supine position, increase hypoxemia and ventilator lengthening. During prone ventilation, the heart became dependent and decreased medial posterior lung compression. The diaphragm is displaced caudally, especially in non-obese patients, and when the abdomen is left unsupported. Decreased compression of the posterior caudal lung parenchyma improve ventilation oxygenation. Cardiac output increase in lung recruitment and reduction in hypoxic pulmonary vasoconstriction. Increase in cardiac output by increase in right ventricular preload and decrease right ventricular afterload. What are the predictors of recurrent maneuver? The best predictor of sustained increase in PO2 during prone ventilation is 10 mm Hg increase in PO2 over the first 30 minutes of prone ventilation, predicted as a sustained increase in PO2 over the next 2 hours. Patients whose PO2 did not increase during first 30 minutes of prone ventilation showed no subsequent improvement in their oxygenation. Extrapulmonary causes for their ARDS seem are more likely to increase their PO2 during prone ventilation than patients with a pulmonary cause. Patients with elevated intra-abdominal pressure appears more likely to increase their PO2 during prone ventilation than patients with normal intra-abdominal pressure. Patients whose chest wall compliance decreases when moving from the supine to prone position are likely to improve their PO2 during prone ventilation. Proning in severe ARDS patient, Prosova trial was proved prone position as an important rescue measurement to improve outcome in ARDS patient. In spite of the fact that a large number of studies have been published, definite guideline for the best method has not been recommended. This is a prone positioning in severe ARDS NAGM 2013. This is a probability of survival and days of involvement. Prone position 16 versus 32% for 20 days mortality, and supine position is 23.6 versus 41% of 90 days mortality. Alveolar recruitment for ARDS. Multi-center recent randomized control trial conducted in 9 countries in 120 ICUs. Control arm was on mechanical ventilation as per ARDS net protocol. Intervention group received pressure control ventilation with fixed driving pressure 15 centimeter water. P was started from 25 to 45 each for 2 minutes after his patient was shifted back to mechanical ventilation with 5 ml per kg, respired 20, flow 30 ml 30 liter per minute and 5 to 100%. P was titrated from 23 and static compliance was measured after 4 minutes. P was decreased stepwise by 3 centimeter and static compliance was measured at each step. Optimum P was the P with maximum compliance plus 2 centimeter of water. After P titration, new recruitment maneuver with 45 centimeter of water, P was applied for 1 minute and then setting changed back to optimum P. Recruitment strategy group has 63.8 mortality, control group had 49.3 mortality in the hospital. At 28 days, 55.3 and 49.3. Recruitment maneuver can exacerbate inflammatory response by overdistension, bacterial translocation, and reperfusion injury. This recent meta-analysis, including seven randomized controlled trials, conclude has no improvement in mortality on length of ICU or hospital stay in ARDS. This is a Journal of Intensive Care in 2018. Recruitment maneuver does not provide any mortality benefit over lung protection strategy ventilation in adult patients with acute respiratory distress syndrome. A meta-analysis and systemic review of the randomized controlled trial. What is recruitability? Every patient of ARDS does not respond to recruitment maneuver. This maneuver can over distended aerated lung unit and worse villi and hemodynamic compromise. They should be used in a patient who has potential for responding to such a maneuver. Lung recruitability could provide valuable information before recruitment application to prevent possible deleterious effect. What are factors potentially involved in the variability of response to recurrent maneuver in ARDS? ARDS related focal versus non-focal, early versus late, severe versus moderate, and associated respiratory tract. Recurrent maneuver related type of recurrent maneuver, distribution of lung perfusion, transpulmonary pressure, timing of application, patient positioning. Post-recruitment strategy, post-recruitment peak. The earlier or vegetative phase of ARDS has better chance for recruitment success compared with the later or fibrotic phase. Patient with extrapulmonary etiology of ARDS has better response to recruitment. Those with diffuse changes on imaging studies have better chance of recruitment maneuver success than those with focal changes. Patient with severe ARDS respond better to recruitment maneuver and high respiratory system elastase is associated with better response to recruitment in clinical trials. What are indications for recurrent maneuver? ARDS acute lung injury. Patient with secondary ARDS, that is example for abnormal sepsis, seem to be respond better than those with primary ARDS, that is pneumonia. Bilateral pulmonary infiltrate, PO2 FiO2 ratio less than 300, that's called acute lung injury. PO2 FiO2 ratio less than 200 called ARDS. Atelectasis during general anesthesia. Desaturation after suctioning from the ET tube. Contraindications for recruitment maneuver, hemodynamic compromise, that is recruitment maneuver cause a transient loss of venous return, compromise cardiac output. Existing barotrauma, increased intracranial pressure, apical bullous lung disease, focal lung pathology, that is lobar pneumonia. What are the complications of recruitment maneuver? Hemodynamic compromise, barotrauma, desaturation. Recurrent maneuver in ARDS improve oxygenation in majority of the patient. Routine use of recurrent maneuver cannot be recommended. It should be considered for use of an individualized basis in patient with ARDS who have life-threatening hypoxemia. Consider ECMO in the sickest patient. Thank you. Now I am handed to the mic to Dr. Kaladhar sir for ventilator settings.
Good evening. Thank you, Dr. Ravi Dosi, for that nice introduction. And that was a fantastic talk by Dr. Vivek Gupta regarding the recruitment manuals and their application in ARDS. So now I am going to talk about the ventilatory settings in ARDS. I'm Dr. Kaladhar S. I'm from the Yashoda Malakpet. I'm the head of the Department of Critical Care Medicine here. So thank you very much, Chest Council of India, for giving me the opportunity to talk on this forum. So ventilatory settings, as you know, in ARDS is a very, very important aspect, and everybody has to know in detail of how to tackle the ventilation in these patients. I think in your previous classes, you might have come across the concept of baby lung, where the normal lung will be there. Along with that, there is the damaged or nothing but the consolidated lung. And without much discussing about that, I will go towards discussing about the ventilator settings in ARDS. So if you look at this figure here, the intensity of intervention, as this is the x-axis shows P by F ratio, PaO2 by F ratio, wherein mild ARDS, moderate ARDS, and severe ARDS are there. So as the spectrum of the disease towards right side where the severity increases, the interventions will depend upon that. So initially, probably if it is mild ARDS, we will get away with doing a non-invasive ventilation. But when the intensity is increasing, patient obviously will be intubated. And then the interventions are like low titer volume ventilation, PEEP going from low, moderate to higher PEEP, probably trying for neuromuscular blockade, prone position, and then echo and ECMO. These are the things that the patient will have to go through the spectrum of why the spectrum of the disease is there, depending upon that. So, what is the ventilator setting goal generally in ARDS patient? If you look at the primary goal is to the lung protection. See the lung protection of the normal lung, which is very important. At the same time, opening the damaged lung. So we'll go about this in and further slides. The topics here covered in my talk are basically I will be targeting on the ventilator settings of how lower tidal volume is important, and because of lower tidal volume, what do you expect the permissive hypercapnia is will be there, and at the same time we'll be discussing about PEEP and related things like plateau pressure, driving pressure at the bedside, how do you monitor and how to titrate your ventilator setting according to those parameters. So come to low tidal volume ventilation. This is a very crucial aspect. There is no other goal other than practicing this. Most of the studies have described that the low tidal volume ventilation being in a practice is very less. So if you look at the lung, which is as I was telling you about baby lung, this is the consolidated lung. So when the air entry happens, suppose if you are giving more tidal volume, the normal alveoli will get to overdistend and consolidated the lung will open. But because of more tidal volume, the overdistension causes a lot of ventilator-induced lung injury, which further exacerbate ARDS. So one landmark study, which is called ARMA trial by ARDSNet study, had shown that in this actually they practiced they were having two arms. One is low tidal volume ventilation, another is high tidal volume. So 10 to 12 ml is high tidal volume, and 6 ml per kg is the lower tidal volume group. If you look at in this graph, where if the patients where the lower tidal volumes have been practiced, the survival is being increased as compared to the patients who were under higher tidal volume group, where that mortality was on the higher side. If you look at in this table, where 31% the death happened in those patients who received lower tidal volumes, as compared to traditional tidal volumes, 39.8%. So it is definitely 8.8% more. So the mortality difference is definitely there. And even in subsequent studies, this has been proven. So the baby lung concept, if you look at the baby lung, which is normal to mildly damaged lung and at the same time consolidated lung. So how do we generally apply this concept at the bedside? So one thing which is important for you is to understand what is predicted body weight. So you have to check the length of the patient depending upon female or male. So you have to apply this equation, and depending upon that, you will be getting the predicted body weight. Suppose for females, it will be 45.5 plus 0.91, height in centimeters in minus 152. So if it is males, it is 50. So as compared to 45.5. So then you will get the predicted body weight, and according to that, 6 ml per kg, you have to put as the tidal volume. Generally, if it has been started as 8 ml per kg, and after 1 to 3 hours, you come down 1 ml per kg in predicted body weight, and looking at P plateau pressure, PaO2, SpO2, the target should be 28 to 30 of P plateau, 55 to 80 of PaO2, and SpO2 has to be around 88 to 90. Even 95% is more. Generally, around 90 is also fine. By this, you have to look at the plateau pressure regularly, 1 to 3 hourly, almost to monitor this, and depending upon that, you come down on tidal volume, even to the extent of 4 ml per kg is very important. So what is the consequence of practicing a low tidal volume ventilation? Definitely, when there is a low tidal volume ventilation, you expect hypoventilation being happening, because of which there will be a retention of the CO2, which will lead to hypercapnia. But hypercapnia, is it really dangerous? Not to the extent we think. Generally, hypercapnia, which is called permissive hypercapnia, where the CO2 up to around 60 to 70 without much of change in the pH. The pH has to be kept above 7.25. Then it also have some beneficial effects, especially in terms of the good effects are hyperdynamic changes. What happens? The heart rate increases, cardiac output goes up, and systemic circulation comes down. And this leads to increased delivery of oxygenation, and lactate clearance will be better. But you have to closely watch out, because of hypercapnia, there will be right-sided pressures increase, pulmonary pressures increase. This also you should be keeping in mind, very important. So then come to plateau pressures. How do you measure the plateau pressures at the bedside? You give an inspiratory pause for 1 to 2 seconds, where you are equilibrating without any flow, zero flow, and equilibrating the pressures with alveolar pressures. In a way, you are measuring the alveolar pressure. So the plateau pressure is a measure of whether alveoli are getting distended or not. So that has to be kept less than 30. We will see why it is important. So you see that ARMA trial, what we discussed in that they even looked at the plateau pressure and mortality proportion. When you look at in this graph on the x-axis where plateau pressure is there, if you up to 30, it's almost a bit high and the plateauing here. But after 30, there is a linear increase in mortality when the plateau pressure goes up. That is very important. That means you are over distending the alveoli, causing more injury and causing the worsening of the underlying lung disease leading to mortality. The plateau pressure is nothing but the transpulmonary pressure plus chest wall pressure, which take into account the addition of this leads to plateau pressure, nothing but the alveolar pressure as we discussed. So next comes another pressure, which is important, is also driving pressure, which has gained momentum in recent years, where it is being calculated as tidal volume by respiratory system compliance. As everybody knows, respiratory system compliance, delta volume change, delta pressure change leading to delta volume change. If you look at this graph on the ventilator, so this is the baseline PEEP, and peak inspirator pressure indicates the resistance, whereas P plateau indicates the compliance. And then how do you look at the bedside, the monitoring of this? The simple thing is looking at the P plateau, and when you subtract minus the PEEP, that gives as a delta PEEP, nothing but the driving pressure. So the driving pressure is very, very important. It has to be kept below 15 centimeters of water. The rationale is nothing but it also is directly correlated with protected lung ventilation, decreasing ventilator-induced lung injury, increasing oxygenation, and then thereby improving outcomes. So if you practice lower tidal volume, lower plateau pressure, and IRP, generally you will aim at the driving pressure to go down. So which improves the stress and strain, and then function size, ventilation will be optimized. This is very important. This is one study where, as I was telling, as in ARMA trial, this is one study they looked at retrospective analysis of different RCTs of around 2,400 patients. If you look at in this graph, where the delta P more than 15, up to 15, the mortality looks to be okay. After 15, the mortality goes up. This is also very, very important. Next, come to the concept of peak and expiratory pressure. So, this is very important because peak and expiratory pressure is nothing but there is, as I was discussing about probable value trauma and barotrauma, at the same time, atelectative trauma. So three traumas are there. So atelectative trauma is nothing but cyclical opening and closing of the alveoli, causing stress and strain on the alveoli, leading to the atelectative trauma. So only tidal volume is being, lower tidal volume being applied. You look at these alveolar components are collapsed, and then will repetitive opening and closing. When you apply PEEP along with that, the alveoli will remain open and they participate in gas exchange, especially the oxygenation is the one which improves, and thereby you will prevent the atelectative trauma. Of course, different studies did not show much of mortality benefit, but it also forms a very crucial point where we have to practice at the bedside. So how do you decide what is the optimal PEEP? So most of the people talk as higher PEEP or lower PEEP, but I tell it is more of optimal PEEP that is important. Every ARDS patient is different. So you look at the pressure volume loop. If you look at in this pressure volume loop, the inspiratory limb where there are 2 points. One is lower inflection point, one is upper inflection point. Lower inflection point is the one where the alveoli will start opening. So if the lower inflection point above to that, if there is a 2 centimeters of water where suppose if it is 14, you keep a 16 teeth, that is generally optimal. If you keep more than that, maybe 20, 22, where the upper inflection point you will be exceeding, it will lead to over distension of alveoli. That is the reason optimal PEEP is decided by lower inflection point, looking at the PVP loop. So incremental versus decremental PEEP. How do you titrate this depending upon the patient worsening or improvement? So that has to be decided looking at plateau pressure, driving pressure, and SpO2 and MAP levels. As everybody know, when you increase the PEEP, the hemodynamics are going to worsen. Sometimes MAP comes down. As you decrease, MAP improves, but saturations come down. Driving pressure may remain same or increase, or otherwise the plateau pressure also comes down or goes up depending upon the PEEP. But generally, incremental time takes more time, it's 60 minutes for fully equipped, but increments 5 minutes. That is the reason you have to be careful while looking at decreasing or increasing depending upon the patient response. Next comes another aspect is neuromuscular blockade. Whether really I have to put the patient control ventilation and do give total full neuromuscular blockade. Now the concept is evolving towards non-neuromuscular blockade, rather more of deep sedation. Previously, there is one study where accuracy study that shown that the mortality benefit when the patients have been neuromuscular blockade happens for 48 hours, mortality is better. But what is the rationale for this? Because when you are paralyzing the respiratory muscles, you expect the active expiration is not happening and there is no desynchrony, which leads to less biotrauma, which leads to improved outcomes. That was the rationale. But recent study, Rose trial, did not show much of benefit. If you look at 90-day mortality between cisarteric versus control group, nothing but deep sedation, the mortality figures remain to be same, even to 12-month mortality also. So we are practicing more and more of deep sedation rather than going for a neuromuscular blockade. Probably in the initial period, if there is patient is too sick, probably for 24 hours, it's okay, but not more than that, which will lead to critical illness neuromyopathy. So these are all lung protection ventilation during assisted ventilation. Of course, the patient will be during most of the time controlled and assisted ventilation will be there. Depending upon the recruitment. So there are some recruitment, the really also comes down. So better VQ mismatching, better gas exchange. If it is under-assisted or over-assisted, it will have its own inherent effects leading to more ventilator-induced lung failure. Under-assisted lung recruitment at worst gas exchange. Higher respiratory drive, which will lead to dysynchrony. And over-assisted muscular atrophy or sometimes PCD, patient self-induced lung infected injury. So this also is one of the concepts which is evolving and which was very much looked at during COVID. And the lungs which are compliant will have large volume, high energy input, and they are being overstretched. If they are non-compliant, it will lead to small volume, low energy input, and tolerated strain. So that is the reason the concept of the mechanical power, as I am going to discuss. So the Willi is nothing but the energy applied to lung, which can be looked at as a mechanical power. The peak, plateau, driving pressure, these all cause damage if there is a volume change which results. So the damage factor is stress and strain. The stress is nothing but the pressure applied to the lung. The strain is nothing but the associated change in the lung volume. So finally, what is important? What is the energy that you are delivering to the lung, which will lead to stress and strain is important. So the concept of mechanical power has come into picture nowadays, where you look at in this equation, if you look at power is calculated in joules per minute, where there is a static compliance of PEEP and dynamic elastic compliance of the driving pressure and P peak and P flat, where the dynamic resistive compliance and all these things taken into account, you calculate the mechanical power. So bedside, generally, if it is a volume controlled ventilation, the calculation depends as 0.098 into tidal volume into respiratory rate into P peak minus 0.5 driving pressure. And if it is a pressure controlled ventilation, then it depends upon time. The equation changes driving pressure plus speed. So healthy subject generally 3 joules per minute. Generally, the recommendation is less than 17 joules per minute. If it is there, the mechanical power, the mortality is better. If it is exceeding more that means the power required to inflate the lung is more. That means the lungs are more stiff, the mortality is going to be. So come to the conclusion, pressure versus volume. So both are relevant for lung protective ventilation, and lung protective ventilation is not only guided by single parameter. As I was discussing, everything is important. Practicing tidal volume, optimal low tidal volume, optimal P, looking at driving pressure, tractive pressure, and depending upon that, how to titrate your tidal volume, speed, and respiratory rate depends on that. So, and then P plateau, driving pressure less than 15, P plateau 28, and mechanical power less than 18 joules per minute. These are all the things, cumulative efforts and cumulative practices leads to good outcome. Thank you very much.
Wow. Dr. Kaladhar, I must hand it to you. That was one of the best presentations on ventilator strategy, and it actually covered most of the relevant topics to in the state of the art manner. Really, it was a beautiful presentation. And now I would like to take things forward by involving my pan India panel on this wonderful chilly night. Now, we have had a lot of ventilator stuff that Dr. Kaladhar has taught us over the past 10 or 15 minutes. And really, I must say, these webinars are uploaded on the CCI channel. Please go through this. Dr. Kaladhar's webinar presentation was very beautiful and was very relevant also. Now, Dr. Vivek, you also did a very good job. But now I would like to bring in our Bihari Babu, our Vinod ji. Tell me one thing, Kaladhar sir ने बहुत ventilator की बात करी, but now let's begin from situations where we are in a doubt, situations which come in the category of mild ARDS. So tell me, Vinod, how do you manage mild ARDS?
So, sir, the mild ARDS patients are those who have a PF ratio of 200 to 300, right? So, generally, the patients are tachypneic. They have a high work of breathing. So, it is preferable to use an NIV. Sometimes, if the patients are not very compliant to NIV, we can use HFNO or NRBM or Venturi mask or something, but preferably it will be NIV. So if the patient are sometimes not non-compliant, we can give them some sedatives like dexmedetomidine or light sedation, which can make them calm, or fentanyl to make them a little calm, so that could they could be compliant to the NIV. We should also be watchful that because the patient may worsen from mild to moderate, right? And of course, other than that, if the patients are cooperative, they can also practice self proning mild hypoxic patients. uh, that's all, sir.
Right. Very, very right. Dr. Kaladhar, I'm really wanting to know that, Yashoda Malakpet, long back when I was in Hyderabad, I used to work there, and it
Oh,
was a pleasure, very updated state of the art place. Sir, in your experience, mild ARDS, sir, how do you manage? They are the most common patients which we see, I feel.
yes, yes. Yeah, the mild ARDS, especially the patient who is coming with some community acquired pneumonia, initial viral and all, probably there might be some infiltrates where they have oxygenation bit lower down. So in these patients, you need a bit of probable opening up of the lung, where, as Dr. Vinod was telling about possible trial of NIV has to be done. And more recently, we are moving towards HFNC support, I think. As everybody know, it's being more tolerated because the humidification is much better as compared to non-invasive ventilation. And of course, most of the times, non-invasive ventilation, as we put it, we don't generally much pay attention towards humidification where we put HME filter. Rather, if it is a heated humidifier, the patients tolerate well. Depends upon how suppose the consolidation is bit more, probably basal and all, then the NIV works better compared to HFNC because you will be able to give a bit pressure support, like the pressure support and along with that PEEP. So in that aspect, both are somewhat okay. But initially, if you are giving HFNC, you have to give the flow should be a bit high, 60 liters, and a patient should not open mouth very frequently, where the PEEP effect of the HFNC will be better. So these two are the things. And
Right.
another important thing is should not increase much of PEEP, which will cause the injury. The PEEP has been shown to be detrimental in these patients. So should be applying low PEEP, maybe 6 to 8, less than 8. Yeah, like that.
Sir, would you pressure like suppose we put the patient on a ventilator NIV, then you go for a pressure control ventilation or a pressure support ventilation in mild ARDS?
Yes. So this forms a very important thing. Yeah, especially the patients who are more tachypneic or having a air hunger, probably we will put them on pressure control to because it gives a control where, but the control has to be more to meet the demand of the air hunger. But at the same time, we want to curtail it down. And if it's more tachypneic, there is a possibility that he can get fatigued. That is the reason pressure control is preferred. But if the patient is not having very much tachypnea and not much of air hunger, probably you can get away with pressure support ventilation. NIV with pressure support ventilation will be better in those patients.
Right.
As
Right.
Dr. Vinod was telling, another important factor is anxiety. So that has to be taken care. Something like a dexmedetomidine infusion, where it helps them calm them, and in that way, I think the synchrony improves in these patients. Yeah.
So from Patna to Hyderabad, we are in unison as how to manage mild ARDS. But whenever a ARDS patient comes to the casualty, first thing is NIV or ventilation, and the second thing is steroid. So I would like to bring in our young prodigy, Dr. Stuti Gupta. Ma'am, tell me what is the current status of steroids? क्या अभी भी ये controversial है कि कुछ proven है?
Very good evening, sir. First of all, I'd like to thank CCI and Krishna sir for giving me this opportunity. So, sir, with the see, first of all, COVID gave us a lot of questions and also a lot of answers. COVID was one thing which actually brought ARDS on the forefront. And after that, there have been multiple meta regressions and meta analysis. And even the recent guidelines, such as the ATS guidelines of 2024, the SCCM guidelines of 2024, they all give us conditional recommendations. So we need to understand what are conditional recommendations. So conditional recommendations is that it's a thing which majority of people would like to do. both as physicians and the patient. But you need to identify the risk benefit ratio. So why now we need to understand why this risk benefit ratio things come. See, problem is ARDS is a very heterogeneous disease, and steroids are also a very heterogeneous thing. If you see studies, there have people who have used DEXA, people have used methylpred, people have used hydrocot, and even the time of initiation, few people are using it in early ARDS, few in late ARDS, and the doses also vary. So what happens when you're doing a meta-analysis? There comes a lot of heterogeneity because you're comparing very different things. So that's why the recommendation tends to become weaker because you can not everyone is saying if everyone was doing the same thing, I would have been more confident. But people are doing it in their way and they have shown response because of which the conditional recommendation is for steroids. However, we need to know the side effects of steroids. See, it's very easy to write give Dexa 20 to patient for 5 days, but you need to know when to stop and what to look for. First of all, the most important thing is the hyperglycemia. The long term effects, whether it is promoting cinema, you will be giving neuromuscular blockades to the patient is immobilized for prolonged. So that needs to be seen. But yes, as the movement, it is recommended, and the main trial which brought this to forefront was the ARDS DEXA trial, sir.
Right. So I think I asked the question from the right person. Being from Delhi, you really know how to answer questions politically in a correct way. So you have very beautifully told कि use कर सकते पर नहीं भी कर सकते और सभी करते पता नहीं.
No,
Sorry to
but
say, but that is what it is. That is what it is about steroids. I know it is one of the most controversial but also most intriguing medicine which we all want to use but don't want to use. So I would like to go carry on this discussion by going to the next very important part of initial management, which is the fluid strategy in ARDS, with the question which I would like to ask Dr. Vinod. Vinod, how would you start a fluid management in ARDS?
Sir, when the patient comes to us, the ARDS generally has an etiology. It could be because of sometimes people are in sepsis, sometimes it's a trauma case, and the ARDS is because of contusion. Sometimes they have a very systemic disease, right? So it depends on, and patients sometimes are febrile, they have fluid loss. So generally accepted thing is conservative line of management, not go very liberal with the fluid, but we have to patients are generally hyperventilating and they have fluid loss as well, and febrile patients also lose fluid. So conservative line of management is preferable, but we have to maintain a urine output of 0.5 ml per kg per hour. So generally the outcome of patients is better with a conservative line of management of fluid rather than liberal line of fluid management.
Right. So one thing very well told Dr. Vinod, but Kaladhar sir is there. Sir, in my last criticare, which I attended as a student in Hyderabad, there was a big debate on two stalwarts from foreign, colloid versus crystalloid. We will give this, we will give that. Sir, how will you manage fluid in ARDS, sir?
Yeah, basically, anyhow, whatever, most of the times the fluids initially have to be the crystalloids. Initial resuscitation generally depends upon how the hemodynamic stability is there. Suppose ARDS patients, most of the times, those who are in severe ARDS, generally they have shock most of the times. So, first initial, generally we look at the fluid responsive indicators. So the most common thing that generally in ICU we practice is looking at a IVC. So inferior vena cava diameter, if it is collapsing or dilated and all. So suppose if it is collapsing and patient seems to be hypovolemic, so probably we'll start with crystalloid. And maybe initially 30 ml per kg according to like septic shock guidelines and all those things. But looking at these indices dynamically, something like we have pulse pressure variation and all, actually helps to how much to titrate the fluid very much. The bedside indicators are very much important rather than just blindly giving much fluid. But once crystalloids, if you think you are exceeding probably maybe 1.5 liter, 2 liters, still you are not able to achieve the hemodynamic stability, that's when probably the albumin, especially the colloid, what we use is albumin because a starch and all, they are proven to be causing nephrotoxicity. That is the reason we use albumin in these patients. Albumin is a good colloid. Probably there are two formulations, 5% and 20%. If you get 5%, that's good. So 5% 250 ml it comes. 20% will come as 100 ml. So 5% can be used as a resuscitation fluid. The advantage here is probably you will be able to come down on the amount of fluid that you give, because colloid will exert pressure, colloid oncotic pressure will be there, and it will remain in the intravascular compartment for more period of time rather than crystalloid. But the problem here is whether it's a colloid or crystalloid, if you give more, at some point they come out of the intravascular compartment and they get accumulated in the interstitium. So which will worsen, because ARDS already alveolar exudates, diffuse alveolar damage and all. So the probability that these patients will worsen later point of time if very much fluid given. So the fact trial that had shown that conservative fluid strategy is better, and we are more and more de-resuscitation strategies we are aiming at. Rose concept, so many things are coming. So where they aimed at de-resuscitation. So first 24 hours is the one where you target and resuscitation, but after 24 hours, look at input output and concentrate how you can reduce on the fluid. Even sometimes looking at, suppose you started meropenem, doxycycline, pantoprazole, some other injection and all. Our sisters 3 times a day, 4 times a sisters tend to dilute them in 100 ml normal saline and all. So you come down 20, you ask them to dilute in 20 ml, and the input totally stop the IV fluids. So these are the measures which are very important. So definitely first resuscitation to target give more fluid, but after 24 hours always target to come down and de-resuscitate fluid, because the fluid invariably going to accumulate in interstitium.
Right. Thank you. Thank you, sir. It was very, very well elaborated, sir. And I think between Vinod and Dr. Kaladhar, sir, we have seen the day one aggressive resuscitation, day two that you have to go for input output. Very clear and crisp message given by our respected panelists on fluid management in ARDS. अब मैं वापस दिल्ली चलता हूं, जहां पॉलिटिक्स है दिल्ली में, वहां पे पावर भी है. तो कमिंग टू द मोस्ट पावरफुल टॉपिक ऑफ ARDS, which is PEEP. So, Stuti madam, tell me, what are the various methods of PEEP setting, please?
Okay, so first of all, for the younger audience, I would like to make them understand what is the concept of PEEP. See, what is ARDS doing? It is making your lungs stiff. Imagine you have a very stiff balloon and you have to inflate it. So you need to give too much pressure. You have to blow really hard at it to blow it. So now what is happening? Your lung has become stiff, but it has not become strong. It has also become weak. If you give too less pressure, you will not be able to inflate it. If you give too much pressure, it will rupture. So that is where the whole concept of PEEP comes. Second thing, what happens is, since these are boggy, heavy alveoli, and they are not at their natural, they are at higher closing volumes than what they are. So basically, they are, even if you give them pressure, they have the tendency to close. So you have to give them a continuous pressure during the respiration. It's not like a natural respiration. That's why there is the concept of positive pressure and then the PEEP. Now, how much PEEP to give? So I would take everyone back to physiology and see there were three waste zones. 1, 2, 3. Okay. So problem comes is, if you're giving it too less, you're not opening the alveoli. If you're giving too much PEEP, you're opening the alveoli too much and it is compressing the capillaries. So you have given the ventilation, but there's no perfusion. There's no blood to take that oxygen that from the open alveoli. So that's why there's this whole concept of adjusting the PEEP. Now, there are multiple methods to do that. I mean, the most famous is the ARDS net table. I am pretty sure everyone has heard about it. So, see what these people do. They did not use some high AI or something. They just gave a table that at this FiO2, you should keep this P. And they found positive results with it. So, that was the first thing that they did. But as we go ahead, we advance and we have more and more methods coming up, because our trials, especially our meta-analysis, have consistently not shown benefits of high PEEP. There's always a subgroup, patients with higher inflammation, patients with severe ARDS, which have shown improvement. So they started saying, should we give PEEP to everyone? Whether I should keep it 8, 16, 24. PEEP table suggests even up to 24. So, if I am a trainee in ICU at night, and if I have to put PEEP of 20, I will think 3 times. So how you can do it? So other methods that people have seen, So there are multiple methods. Best, easiest is if you have an ultrasound, start putting the ultrasound to the chest, see the PEEP at different level and see the number of B lines you are getting. That's the basic method. So second is another easy one is see your PV curve. So as sir has shown previously in that PV curve, there is a lower inflection point and there is a higher inflection point. You have to choose a point which is somewhere below the higher inflection point and which is giving this optimum peak. Now, see, again, there is a problem. There is a concept of baby lung. So, ARDS is heterogeneous. कुछ part अच्छा है, कुछ part खराब है. When the ventilator is giving the pressure, if let's say I have set a PEEP of 16, that 16 is going to normal lung, that 16 is going to the abnormal lung as well. Bad lung needs that 16 ka PEEP to open up. But what about the normal lung? If I take a normal balloon, if I start giving it too much pressure, won't it rupture? And that's what predisposes you to Willy. So they saw when you are doing this ARDS neck table or doing just this lower inflection point, higher inflection point, there is a lot of regional differentiation. Some areas are receiving too less PEEP, some are receiving too much PEEP. So they started going into newer concepts. So what are the newer concepts that are coming up? So one such concept is driving pressure. So what is happening in driving pressure is see, generally, whenever you get a ARDS pressure, you're supposed to measure the height of the patient and calculate the ideal body weight. And you are supposed to set your low tidal volume based on that. 4 to 8, generally we set it around 5 or 6. Now, what is happening is you're calculating the ideal weight on the height of the patient. कि मेरा lung इतना है, इसको इतना हवा दे सकते हैं. But no, this is not your normal lung. That itna lung is not normal. Normal is baby lung. So driving pressure is when you are targeting the things according to the baby lung. And it's very, as Kaladhar showed, that it's very easy. You just have to do P flat minus PEEP. And multiple studies have shown that as your driving pressure is rising. So एक बहुत basic बात मेरे को driving pressure मतलब कितनी जोर से हवा देनी पड़ रही है गुब्बारे को फुलाने के लिए in a very late term manner. तो जितना ज्यादा प्रेशर है इंट्यूटिवली ये भी आप समझ सकते हो लॉन्ग इतना ही स्टिफ है उतना ही खराब है and that is what our studies have shown. The study that sir showed of NEGM by that showed that consistently if you have values above 14 and 15 that increases your mortality. So that is one concept. Another newer concept that is coming is using esophageal pressure. So now as we have driving pressure, another thing is transpulmonary pressure. So transpulmonary pressure is so this is a ventilator machine and this is the lungs at a whole. So how much pressure this whole ventilator is giving to the system as a whole to inflate the lung. When we are seeing transpulmonary pressure, we are looking at all compartments of the lung. We are looking at the airway, which is the resistive work. We are looking at the parenchyma, interstitium, pleura, chest wall, which is the elastic work. So transpulmonary pressure is taking account into the whole pressure that is being given to the respiratory system. Okay. So esophageal pressure tries to keep your transpulmonary pressure positive at the expiration. So what do you do when your patient is ventilated? You put one more probe. You put it through the nose and you put it in the esophagus. So it's like how you put your RT. जैसे आप अपना राइस ट्यूब डालते हैं उसकी जगह आप esophageal probe डाल रहे हैं. And it is said you have to set it in the midline. So you can check it with the radiographic. There's Boyd's method. There are multiple methods. You can do positive occlusion. See, this is a very important step क्योंकि अगर आपने बहुत ऊपर रखा esophagus में या बहुत नीचे रखा आपके पास गलत प्रेशर आएगा. So which that so they feel that the esophageal pressure is a corollary of pleural pressure. So it would be very traumatic if I put a manometer in the pleura of the patient. First of all, you are making a new space for the infection. Esophagus is something which is day and out exposed to the external thing, but pleura you cannot put a new catheter. So you are taking a corollary कि pleural pressure को हम esophageal pressure से measure करेंगे, and we try to keep the transpulmonary pressure positive in the expiration. However, as I said, that there is a heterogeneity in ARDS itself. So the study still now F1, F1-2 has been negative. I would like to quote a paper which was published in Chest in 2022. It's a very beautiful paper and I think everyone should read it, and it is called Misestimation of Trials in ARDS. It's like something that intuitively feels should work, but it is not showing in trials. Why it happens, and that paper talks about the heterogeneity itself. So that is, I think, again is the case with esophageal pressure as to why it has not shown. The latest ICM guidelines also do not recommend any particular method. Like they do not say that you should go and put the esophageal pressure to measure it. That is best. They say you should use high P, but they do not advocate any particular measure.
Right. Right. Very, very, very well answered. Matlab, really, the PEEP concept you have explained, I think Dr. Kaladhar and yourself have made a very good representation of what PEEP actually helps, the heterogeneity, the problem, the newer methods, driving pressure. Everything has been very well elaborated by you, Stuti. My compliments on a very, very lucid explanation. Now, like moving along, as we ventilate the patients, there are several problems. Like you told that if the PEEP goes more, it causes issues. There are several sort of problems that the ventilator itself can cause. So I would like to call in Dr. Kaladhar, and I would like to tell you, sir, there are several issues that we are often coming around when we hear about ventilating patients. For example, I would like to ask several of these issues to you. Beginning with, we commonly hear about volume trauma. So, what is volume trauma, sir, and how can we prevent it?
Yes. So the volume trauma, as we were discussing about the low tidal one, that was very well explained by Dr. Stuti Gupta. So the lower tidal volume ventilation, that's what we practice according to the landmark study ARMOR trial. So if you are exceeding giving that volume, generally that leads to the volume trauma. That means you are the baby lung concept, as again we stress upon that. So when the volume is more, you tend to over distend the normal alveoli and damage the normal alveoli. And this leads to the stress and strain on those alveoli. The main concept is that. So when the alveoli get damaged, so it leads to biotrauma generally. So the ARD is already such an inflammatory cytokines, mediators, these all lead to the biotrauma. When the alveolar overstretched, that also leads to lot of cytokine storm, which will lead to further biotrauma. So the concept here is to concentrate on how much tidal volume you are giving. So this is the reason most of the times initially between volume control mode and pressure control mode, probably you prefer to use volume control mode because you will have more control over how much tidal volume you are giving. Because the pressure control mode, suppose you put some 16 pressure control initially, as the patient lung opens up, initially it may be delivering around 400 tidal volume. Suddenly the lung opens up, you may be tending to give more tidal volume because the lung stiffness comes down and it suddenly delivers maybe 450, 460 tidal volume. So that is the reason you should have a control over the tidal volume initially. So whereby you prevent this stress and strain on the normal lung and over distension leading to further injury of the lung. So this is basically the volume trauma. So
another very commonly heard trauma is barotrauma. Like all of you are discussing pressure and volume. So volume you have explained, sir. What about barotrauma?
Yeah, the barotrauma is also the same thing, like the strain which will be there on the lung. So whenever there is high pressure applied, it will lead to definitely, which we were talking about driving pressure and plateau pressure. Why we are targeting them? Because when there is the pressure which is with which we are inflating the lungs, if it is exceeding whatever we expect, the plateau pressure more than that, or driving pressure more than that, it will also lead to the same. The bottom line is the stress and strain on the lung will go up. So this suppose same thing like a pressure control mode. So wherein probably especially to come to a volume control mode. So you are giving a tidal volume where it is 400, and suppose the pressure required to give the tidal volume exceeds maybe suppose 40 or 35, that plateau pressure which is being reflected, which is nothing but a static compliance. That means you are causing a pressure which being given to the lungs to cause the barotrauma. So invariably you practice the low tidal volume, generally it leads to again leading to a lesser pressure required to open up the lung. So more or less both are interlinked actually, if you can speak. So
Very good. Now there are few means since the last time I read this topic, now I have come across some new traumas that we can do for the patient. I would like you to put some light on that also. Namely, there are terms like ergotrauma, myotrauma, and atelectotrauma. If you could just
Atelectotrauma.
elaborate them for us, sir, please.
Yeah. The atelectotrauma, the same thing. The concept for PEEP is to reduce the atelectotrauma. The atelectotrauma causes what happens if you are not able to give end expiratory pressure, the cyclical opening and closing of the alveoli will be more. So once they are opening up and closing with sometimes need a pressure which we have to open up, and because of which the walls of the alveoli will get stress and strain. So if you are keeping them remain open like that, rather than just cyclical closing and opening, so the possibility that whatever the stress and strain on the alveoli comes down. So that is where the concept of PEEP comes. When you are applying a peak and expiratory pressure, so at the end of the expiration, the alveoli keep remaining open and the gas exchange also happens better, and the repetitive closing and opening of the alveoli will be less. So whereby you prevent that atelectotrauma. The atelectasis, nothing but the closing of the alveoli and sudden opening of the alveoli. So come to ergotrauma, more and more concept nowadays are concentrating on mechanical power. The power that you give to the lung, which will open the lung. So as I was telling, in normal healthy subject, the power will be less than 3 joules or something like that. But generally, in across different studies, what they have looked at is if the power goes up to more than 17 joules per kg, generally these are the patients who are very bad. So you require a lot of power to open up their lungs, which indicates the underlying disease is very bad. Probably all measures like driving pressure, plateau pressure, PEEP, everything, respiratory rate, even chronotrauma we call as respiratory rate also we generally target more 35. But once patient getting better, probably we have to come down, giving more respiration, which will cause like the cycles per minute from where the alveoli keep remaining open and closing also induces trauma. So these are all being concentrated in one equation where I was telling about mechanical power. It's nothing but it concentrate upon decreasing the ergotrauma. So the power you have to come down, the power that which will be transmitted to the lungs to inflate has to come down. If you take these measures of concentrating all these things, automatically the ergotrauma comes down. So that is in a way, in toto, call it as ergotrauma. So another thing, as you was telling, you were asking about is myotrauma. So the myotrauma is nothing but most of the times these patients, the ventilator-induced diaphragmatic dysfunction or otherwise VIDD we call it as. Suppose any patients who are on ventilator, for example, I was telling about neuromuscular blockade. If you prolong it, the neuromuscular blockade, there will be disuse atrophy of the diaphragm. At the same time, if you are inflating the lungs with much pressure, probably there will be stress and strain even on the diaphragm. That's what the generally the ergotrauma transmitted across to the diaphragm. So which will lead to myofibrillar damage, and then it leads to ventilator induced diaphragmatic expansion. How it is how it translates into clinical outcomes. Of course, when the patient gets better, when you are weaning, suppose there is a diaphragmatic dysfunction, this can lead to the delayed weaning or prolonged weaning, and then probably the patient will develop secondary infections once the patient is prolonged on the ventilator for long periods. So this is in a way called as myotrauma. So these are all different traumas. Most of them are interlinked together.
My God, we can be so traumatic if we have not heard this lecture. So thank you, sir. You have really highlighted all of these separate traumas individually. And this becomes very helpful for us because, see, the first dictum is to do no harm. So I think all our settings initially, late night also, whenever you're doing or starting your ventilation, then you have to be careful that don't do any harm. Try to remember all these traumas. And even when you have a prolonged ventilator case, you should remember that there are a lot of issues which can happen to the atelectasis, alveoli, and the muscles over a period of time. So, Vivek, kahan bhai? Vivek sir? I wanted to ask you, Vivek, one thing that
Yes, sir.
at times this sir has talked about trauma very beautifully. Stuti has told us about PEEP. But at times, we, despite everything, oxygenation doesn't improve, and ulta carbon dioxide starts increasing. And some knowledgeable attendants also pick up the ABG and show us, डॉक्टर साहब चल क्या रहा है? तो बताओ यार, ये परमिसिव हाइपरकैप्निया क्या है? व्हाट इज दिस परमिसिव हाइपरकैप्निया?
So first of all, I will good evening to all of you, and thank you for CCI members to give me this opportunity on this platform. Sir, permissive hypercapnia is a ventilation strategy to allow the unphysiological high partial pressure of carbon dioxide to prevent the protective ventilation with low tidal volume. First of all, sir. In 90s, there is the Amata et al. Study is there. We can randomize controlled trial shows lung protective strategy ventilation with low tidal volume to permissive hypercapnia with standard therapy, and he observed that there is a reduction in mortality. So and permissive hypercapnia can also reduce the lung injury, and it can reduce the inflammatory markers is there for inflammatory pro-inflammatory marker is there, and to decrease out and prevent the and give the outcome also and improve the outcome also of the patient.
राइट राइट राइट। नहीं, बिल्कुल सही बात है। आई थिंक अगर आपने आपकी ये लाइन ही अटेंडर को सुना दी ना, तो आई थिंक ही विल बी क्वाइट एनीवे दैट परमिसिव हाइपरकैप्निया कुछ ना कुछ अच्छा ही हो रहा है, आई फील। बट इट इज अ ब्यूटीफुल लंग प्रोटेक्टिव स्ट्रेटेजी, हेल्प्स अस टू ऑप्टिमाइज ऑक्सीजनेशन एंड रियली स्टिफ लंग्स. But again, means I know point of controversy, but Dr. Kaladhar sir, tell me, in permissive hypercapnia, how high can we let the CO2 go?
Yeah, the pervasive hypercapnia, very important thing is to look at the pH. Most of the times, the pH should be kept more than 7.25. Probably, most of the times, if the PCO2 remains at 60 to 70, more than 70, once it goes, probably it leads to the respiratory acidosis. There are some studies where they even used bicarbonate infusion to improve the bicarbonate so that you will be able to compensate for the excessive CO2. So by that, the motto is to target on the low tidal volume ventilation. There is a very interesting concept of ECOR, extracorporeal carbon dioxide removal. One trial, it is called as supernova trial. So where they concentrated ultra lung protective ventilation, leading even up to 3 to 2 sub 3 IR. The lower limit is 3 ml per kg, where you expect the carbon dioxide going up to 90, 100 and more than that, and they put a ECOR, corporeal carbon dioxide removal, because it is bit easy procedure, not that complex as compared to ECMO, and they removed carbon dioxide to compensate for the acidosis, and this way they are able to protect the baby lung. Of course, in that trial, not much of mortality difference, probably it paves the way towards probably more studies to go for maybe ECOR and ARDS to remove the CO2, and at the same time looking at ultra protective lung ventilation. Maybe coming days we may have to look at those studies if they come. So which becomes easy. Even sometimes even the second tier cities also, the performing ECOR is less complex rather than performing ECMO. We have to see.
Right, and I think this is a very important point of permissive hypercapnia. All of us using conventional ventilation need to do it in order to oxygenate your lungs. So a thing like ECOR can be a real boon to our Indian critical care population. Now, Dr. Stuti, see, अब बहुत प्रेशर हो गया भाई. There has to be some pressure release. अब हमारे लंग को बचाओ और ये प्रेशर रिलीज के बारे में बताओ.
So there have been multiple new ways. We're always searching for new ways, new modes where we can decrease this concept of villi. So one such thing is airway pressure release ventilation. Honestly, airway pressure release ventilation is not something new. It was first described in 1987, but gradually we are having more and more studies on it. So what are the important points in it? So first of all, it works on open lung strategy. Open lung strategy is give high PEEP, keep the lung open. Second, it is inverse ratio. Normally, when we are breathing, the I is to E ratio on ventilator is generally 1 is to 2, 1 is to 3. But here we are altering the ratio. We are keeping the inspiration pressure, the TI high, is higher than the expiration pressure. And third thing is this mode allows spontaneous breathing. You do not need a totally paralyzed and deeply sedated patient. So these are three very salient features of APR. So I'm sorry I don't have a infographic at the moment. Otherwise, there's a very beautiful diagram which shows what is basically APRV doing. So as in BiPAP, we have two pressures. Same thing is happening in APRV. But what is happening is we are keeping the patient on higher level of pressure for a longer time. So you might have heard of a concept. We even do it in our pressure. So this came from pressure regulated inverse ratio ventilation. So you might have seen at times senior consultant would be increasing the inspiratory time to improve the oxygenation.
Yes,
So what they're
inverse ratio ventilation.
so what basically they are doing is they're keeping that high level of pressure for a little longer time so that the alveoli keeps opened up and that there is an improved oxygenation. So the same thing is happening in APV, ARPRV. Your the patient is oscillating between a higher pressure and a lower pressure, and the time you spend on high pressure is more. And now what is happening because you're spending more time on the PI, the CO2 removal is low. So in between, with the time that the investigator says, the pressure suddenly drops to the lower level, almost to zero, which allows for the spontaneous breathing to happen more naturally and CO2 to be released. So that is what APRV is. The best thing about APRV is there have been multiple studies. So there was a study by Putenson et al. There have been meta-analysis in which they have shown that it reduces ventilator days and by corollary hospital days. So none have shown the mortality benefit, but yes, they have shown the decreased number of ventilator days. Uh,
Hmm.
Second thing is with the APRV, there is a less chances of asynchrony and less chances of delay because you are not the pressure that is set. That there are three variables you are setting: the FiO2, the P high, P low, Ti, and T low. There's a comparison with controlled mechanical ventilation. The range of volume that is being delivered by the VCV is comparatively higher to APRV. So APRV tends to give lower tidal volumes as compared to VCV. So again, it is more protective. That is the concept of it.
Right. But I think I understood why APRV has not become very popular because although no proven benefit on mortality, but it decreases the number of ventilator days. So definitely not looking to be a good proposition. Very strange because APRV sounds as if we have got the ultimate mode, but still we in clinical practice we are still not coming across a lot of APRV being used, at least in my clinical
Yes,
setups.
sir.
But
Definitely.
Yes.
from the way you have explained it, I find it a very attractive and a good mode. And I think the newer like जैसे हमारे विवेक गुप्ता जी का नया हॉस्पिटल है, अब वो वहां पे लोगों को जीवन दान दे रहे हैं, तो एपीआरवी वाले वेंटिलेटर अगर ले लेंगे तो डेफिनेटली जीवन दान देना ज्यादा इजी रहेगा। क्यों विवेक भाई?
सी सर।
बिल्कुल। तो अब मेरे को विवेक भाई ये बताओ, हमने बहुत बात कर ली, देखिए स्तुति मैडम और कलाधर सर ने और हमारे विनोद भाई ने पल्मोनरी एआरडीएस मतलब निमोनिया के पेशेंट एआरडीएस में गया, व्हाटसोएवर रीजन, डायरेक्ट कॉज ऑफ एआरडीएस में बहुत ही अच्छे तरीके से दे हैव टोल्ड अस हाउ टू मैनेज दीस पेशेंट्स। नाउ टेल मी, देयर आर सम केसेस व्हिच विल कम टू यू विद एक्स्ट्रा पल्मोनरी एआरडीएस, मतलब एआरडीएस द etiology is from somewhere outside. How do you manage these patients? Is it somewhat different from our routine management?
So first of all, we have to see the cause. There is a extra pulmonary ideas. This can cause like acute pancreatitis is there, trauma is there, or trolley is there, multiple blood transfusion reaction is there. Yes. So we have to manage. This is a management of multidisciplinary approach, sir. Early intervention and observation and monitoring. So we have to go for first of all, so there are multiple strategies. You can go for management. Then first of all, we go for mechanical ventilation with a low tidal volume or a high end expiratory pressure or prone positioning. Second is fluid management, sir. Fluid management is done due to and but overfluid is to be avoided due to there is a cardiac edema, overload is not there. Third is manage the cause of that. If the sepsis is there, you can add broad spectrum antibiotic or proper outcome is there. And then is acute pancreatitis is there. There our pain control is there. Enzyme replacement therapy is there, and the trauma is there. If there is trauma management, then stable the hemorrhage side or hemorrhage side and fluid management is there. or if there is villi, if there is toll is there, multiple blood transfusion reaction is there, then you have to give the diuretics is there, or you can go for mm, cone ventilation there. And the other therapy is there like septic stress ulcer is there. You deep vein prophylaxis is you can take care for that. And if there is patient is refractory hypoxemia, not give the response on optimal ventilation, then go for ECMO.
Right, right. But tell me, Vivek, one thing to you will also agree that the bigger problems came in heterogeneous ARDS, which was seen in pulmonary causes or direct causes of ARDS. But one advantage, maybe slight, is that the extra pulmonary ARDS is usually more homogeneous. So managing it becomes a little simpler, I would say, for the intensivist, although not that simple. I agree with whatever you have told that the primary control of the reason causing it is very important. So, Pranay, Vinod bhai, tell me the extra systemic management, like we are trying to manage the patient in toto. So, how would you manage the neuro and hemodynamic parameters of a ARDS patient?
Yes, sir. So, an ARDS patient probably on a ventilator. So we need to give him adequate sedation. As Dr. Kaladhar sir has already told us, deep sedation is considered slightly better than giving muscle relaxation. Uh, uh, the patient on a ventilator should be if there's some asynchrony, we have to see the ventilatory management of the patient. There is ARDS associated with sepsis. We'll have to give fluid management, broad spectrum antibiotics. There are also systemic manifestation of ARDS. Patient may have AKI. We'll have to manage them with fluid or dialysis accordingly. Patient do get ARDS patient do get secondary VAP also, catheter-related infections, UTI. Clap C, clot E, which we get. We have to, prevent them first by hand hygiene and infection control methods, and we have to diagnose it and treat it. Most of the patient with high PEEP will have, generally cardiac output is affected. So if they're in shock, we'll have to see accordingly. We'll have to reduce the PEEP. We'll have to give them vasopressors.
Quite right. No, I agree with you. But Dr. Kaladhar sir, tell me that Yashoda Malakpet is a very, very busy ICU. And this monitoring of neurology and hemodynamics in your regular patients, sir, like my question is in a way that the daily rounds that you take, what are the parameters of neurology and hemodynamic monitoring that you take care of, sir?
Yeah, definitely. So basically, what happens is whenever any patient, suppose this patient, especially severe ARDS, there is not much you can wake them up because we practice deep sedation. So other objective evidence that you have to look at is most of the times pupillary monitoring. Bedside pupillary monitoring plays a very important role. You don't know suddenly this patient might have developed some cerebral edema because of some underlying cause and all. Even we had seen some patients dengue and all. They present with ARDS where they develop cerebral edema. Suddenly, you are doing everything managing this patient, especially in the context of ARDS. Suddenly, there is a pupillary dilatation, not reaction. So, regular pupillary reaction is very important. Suppose at the same time, probably if the patient is getting better up to 24, 48 hours, intermittent sedation intervals have to be given to look at the really patient waking up or not. Some patients, especially elderly, they subsequently develop strokes and all. The background comorbids. That is the reason you have to look at. And another thing we practice where you expect probably a cerebral edema, we look at optic nerve sheath diameter. That is more and more into the practice nowadays. So where the optic nerve sheath diameter, where you put a probe on the eyeball with good jelly, and there will be a optic nerve trace comes. So that diameter, if you look at, if it is more than 5 mm, generally it indicates probably underlying there may be cerebral edema development. So this is one thing which helps. Suppose if you suspect any patient, these patients can have non-convulsive status epilepticus sometimes, underlying if they develop some encephalitis and all. So you look at EEG, how the EEG, and depending upon that also, these are different neuromonitoring modalities. Hemodynamics point of view, as I was telling, yeah, definitely put in a arterial line. These patients are very sick. Arterial line gives very good praise, continuous beat to beat BP measurement. In the arterial line, if you want fluid to be given and all pulse pressure variation, what I was telling, that can be looked at. And if you have some advanced monitoring, sometimes we look at even cardiac output monitorings also. Flow track and all are there. We have a flow track, but advanced monitoring is more of PICO monitoring, where you even get extravascular lung water index. So in a way, you look at the fluid responsiveness. If the extravascular lung water index is going up, that means you are overloading the lungs with your fluids, probably where you come down. And yeah, of course, this advanced monitoring is not very much in different centers, but if it is there, that gives a very good way. So, and other than that, yeah, the non-ventilator management we call generally in ICU as fast track BAD, we call as. So one thing is feeding, the analgesia, sedation, thromboprophylaxis, DVT prophylaxis, head end elevation to prevent pulsar prophylaxis, glycemic control, which is very important. And at the same time, looking at bladder and bowel, how it is, the bowel, whether opened up or not, indwelling catheters, paying attention whether it is really required and you have to remove any infection, as Dr. Vinod was telling about the catheter-associated infections and all others have to be paid attention. And D for de-escalation of antibiotics. Once you send, you get some culture, and whether you started with initially maybe broad spectrum antibiotic and you get a de-escalation, or probably looking at escalation or de-escalation depending upon culture sensitivity reports. These other things also have to be keep in mind.
Right, right. Excellent. So means I think we have practically covered a lot in our short time, and you have really the non-ventilator management of ARDS, that this is a very, very important part, because you might keep on thinking about the ventilator, but sometimes the other things will start troubling you more if you don't pay attention to it. Kaladhar sir, I would like to also try to get your comments, and I would like you to enlighten us about the nutrition of these critically ill patients. There is also one question of one of our panelists on the role of IV glutamine for ARDS, sir.
Yes,
Please,
sir.
I would like your comments on these points, sir.
Sure, sir. Yeah, basically, the nutrition point of view in ICU, especially the ARDS, which is definitely hypercatabolic state. So the patients, we are not paying attention of this nutrition of these patients. They are going to have, the concept is nowadays sarcopenia. So their muscle loss will be more. So eventually they develop, the problem here is critical illness neuromyopathy. These patients eventually develop CINMP. You come out of the underlying cause, and but the patient is totally weak to come out of the ventilator, and they subsequently develop problems. So how we generally look at the nutrition is, initially the nutrition always starts with screening. So the underlying problem, the patient baseline nutrition, whether it is very obese, whether it is okay optimally nutrition, or whether the patient is maybe cachectic borderline. So depending upon that, starting across all studies, they say first 2 to 3 days, you will target the nutrition will be on the lesser side. The nutrition when you are targeting is, one thing is calories, and then proteins, and other things like micronutrients, antioxidants, and trace elements. Everything is important. But the most important, first and foremost, 1 to 3 days you target is calories and nutrition. The calories generally in ICU, that what we target is 25 to 30 kilocalorie per kg. But initial periods of time when the patient is very sick, having a severe hypoxemia, or there will be shock, you will not target very high calories at this point and very high protein. Probably you start trophic feeding, something like you aim for a 75 ml per hour RT feed, but you target maybe 20-30 ml per hour. And then slowly after 2 3 days, once the patient you feel getting stabilized, you ramp up your nutrition to meet 70 to 100% of your goals. So the protein that what we target is 1.2 to 2, but when the patient is hypercatabolic, the protein has to be targeted at least 1.5 gram per kg. Initially, maybe half of that, 1 to 2 days, maybe later slowly 1.5 gram per kg. So this is very important. Along with that, you have to look at whether trace elements are there, whether micronutrients are being provided in adequate quantities and all. And coming to the glutamine, we call the specific broad term is immunonutrition. So immunonutrition consists of probably omega-3 fatty acids and even arginine, glutamine, everything being tried. But the glutamine did not much show the mortality benefit. One landmark study is there, which is called the redox study. It did not show much of mortality benefit, more so infectious complications are a bit more. But more so, these hypercatabolic patients, something like severe ARDS and polytrauma, burns, these type of patients generally, if you supplement enteral glutamine rather than oral or enteral glutamine rather than the IV glutamine. IV glutamine has been shown to increase the infectious complications, and enteral glutamine, at least 10 grams twice daily, maybe 20 grams aiming at 24 hours will generally help decreasing the length of stay and mechanical ventilation in some studies. It can be still practiced, but the redox study did not show much of mortality benefit. Probably if you want to give glutamine, give enteral glutamine. You get sachets generally, glutamine sachets and all.
Right, right, sir. All your points stress enteral more than parenteral.
Yeah.
That is very important, that an adequate and even excess caloric intake in the initial phase, followed by a balancing out to take care of the initial catabolism that we see. Or very well, actually, all this extra ventilatory part that you have talked about, sir, is so important in the management. I would say it is somewhere equal or even more than the ventilatory management of an ARDS patient. So the other aspect, like Dr. Vivek, tell me now, what are the special pharmacological agents that we can use in ARDS? Are there some newer drugs which are showing promise in this particular group? I would like to tell you that I would want a concise answer, because we might even be having a very bigger and elaborate discussion in subsequent ARDS webinar topics on this particular issue. So please tell me, sir, about pharmacological management of ARDS.
Sir, there are so many drugs, but there is controversies is there. No one proven trial is there. So first of all, we have to go for neuromuscular blocking agent. That sir was Kaladhar was there is Rose trial and Accuris trial is there. There is no mortality benefit is there. And another is corticosteroid. We can, but it can also be depend on the late versus early versus late phase is there. And then there is a third drug that inhaled inhaled prostacyclone nitric oxide or restricted pulmonary agent, sir. These are the novel therapy which can give, and another therapy is there which one under study, like statins is there, beta agonist, surfactant is there, and GMSF is there, or mesenchymal stromal cells is there. The newer drug is avitaptadine is there, which is inhibited by receptive uptake is there, which can in type 2 cells. It is given in a dose of 50 to 150 picogram per ml per kg, modified over the escalated dose over 12 every 12 hours for 3 days.
Okay. So I agree. Thanks for keeping it concise, because we're having a much, much more elaborate discussion on this subsequently. Now, tell me, Dr. Stuti, I would like to bring you in on this particular very concerning phenomena of self-inflicted lung injury. Can the patient also cause a self-inflicted lung injury?
Yes. Again, I'll do a brief thing, sir. So basically, what is happening? You have a lot of stiff lung, so you need a lot of pressure to inflate it. When you're not giving any pressure support, when you're not providing any assistance to the patient, let's say when the patient is at home, so when he has just come. So what is patient trying to do is trying to take, he has to put, his muscles has to put a lot of pressure to inflate that stiff lung. And how do we do that? By generating more and more negative pleural pressures. What is patient trying to do? The muscles are putting too much pressure, they're pulling the pleura too much, there's too much negative pressure. So because of that, especially in the dependent part of the lung, the patient tends to get ground glassing, because this high pressure tend to disrupt the vessel at the lower level, which causes exudation. So what is patient trying to do? पेशेंट बहुत मेहनत कर रहा है कि जो बचा कुचा लंग है उससे सांस ले सके, but by doing that, it's like a two-edged sword. He's putting too much stress on the lung that the lung has started producing new injury. So this is a concept that is called TCL, patient self-inflicted lung injury due to their excessive effort. And there were some initial trials by Gettinoni and Garnier, Papazian. They were the first one who postulated that this thing might be happening, and that to prevent this, we might have to sedate the patient. We have to decrease this respiratory drive of the patient, and we might have to sedate them. And that sedation can be something like as simple as a Dexmed, Fenta, to something that at times the drive is so high that the patient might require neuromuscular blockade as well. So it's a two-way thing. See, if you completely paralyze the patient, you're putting the diaphragm at risk, you're not ventilating the dependent region, you're putting things at risk. But too much vigorous effort is causing this problem. So you have to find a balance between this.
Right, right. You're very correct. And I think somewhere we need to understand that once we make the patient from a semi means a totally paralyzed and sedated patient, once he comes out, there are several issues which can happen with the positive pressure that we are giving to the patient. That definitely is
One
an
point I
issue.
like to add more, sir. So see, there is no guideline कि आपको हर किसी को sedate करना है या हर किसी को sedate नहीं करना. This is a something you take a call based on patient. आप रोज patient को देख रहे हो, उसका कितना respiratory rate चल रहा है, how much is the accessory muscle use, that basic vitals जो हम examination में पढ़ते हैं ना, journal examination में, they are the ones which will guide you whether this effort is harming the patient or it is benefiting the patient. So that is where your clinician wala thing comes up, sir. So no guideline can actually ever guide you in this.
Right. This is, and I'll even like to bring in Dr. Kaladhar sir, that this problem, like let's say one simple event which becomes very complicated at times is self-extubation. Like in your ICUs, do you see self-extubation happening?
Yes, sir. Yeah, that is a universal phenomenon. So the problem with self-extubation we do see across the world also. There are many studies where the patient, of course, while weaning, especially, you will be keeping them off sedation. This becomes a problem, self-extubation. And another important thing, proning, probably, I think, subsequent lecture will be discussing. So this is where sometimes not paying attention, suddenly the tube comes out. The problem, these are different scenarios, of course. When the patient is sick and suddenly the tube comes out, it is going to be very dangerous. So you'll not have much time. The moment you start organizing everything, the patient may go down very badly. And the another thing, when the patient is getting better and you stop sedation to look at giving the sedation awakening trials, and you are a bit skeptical about whether to extubate this patient or not, you wait one more day like that. Sometimes you're totally off sedation, suddenly you are somewhere and sisters are doing their job, suddenly the patient pulls out the tube. So they looked at even studies. Once the patient pulls out the tube, probably underlying condition might have been got better. So you leave them like that, or otherwise apply some HFNC or NIV support initially, they will do better. So the thing is, once the patient gets extubated free, and even after extubation, the assessment is important. So there is no, it should not be like you jump in and intubate the patient most of the times if the patient is in this situation. Probably they may get better even. In my experience, I had seen where the patient self-extubated, they were doing good. That means the physician was delaying the extubation and patient did the extubation. So that can be things.
Right.
Yeah.
I remember sometimes when we were residents and our boss didn't used to agree, we used to try somehow कि ये हो जाए self-extubate.
छोड़ दो ऐसे ही छोड़ दो extubate कर लो, patient will get better. That's interesting concept.
Now I think we have had a very good discussion, but Dr. Vinod, most important is suppose ARDS patient extubated, self-extubated, we only extubated. Now the follow-up, the rehabilitation of that patient, and sometimes post ICU also these patients tend to need a little more care. So would you highlight us on what are the points of that care?
Right, sir. So patients usually in ICU during his course of ARDS are exposed to ventilator-induced lung injury. They are exposed to multiple drugs, steroids, muscle relaxants, and there is some residual fibrosis in the lung also, which could be seen. Generally, the ARDS patient, when they recover, they generally the lung function usually comes to normal by 6 months to one year time. But the neurocognitive effects of ARDS, the delirium and other things, the neurocognitive, the decision making, that can take some time. Usually, the patients are have some neurological dysfunction for next 1 to 2 years. Other than that, they are systemic. Mostly the rehabilitation, the muscular weakness. It generally takes time. So we have to give good nutrition to them. Counseling. Generally, when the patient is shifted to a room, uh, proper sleep, family time, all that helps patient generally to recover post ARDS. And we have to
Right.
follow up them, do a lung function. We can do follow up X-rays or sometimes CT to look for any residual effect of the ARDS.
Right. Very well told that neurological rehabilitation, physiotherapy, and like Dr. Kaladhar told us, sir had told that nutritional aspects have to be taken care of. That is very correct. So I think in total we have discussed several aspects of managing a ARDS patient, both ventilator wise, non-ventilator wise, and medically, nutritionally. We have covered several aspects, and with this, I would like to also now call upon all my panelists to give just a take home point which they feel is most important for our panelists, for our audience to know. Just one take home point from all of you. I would be asking, beginning with you, Dr. Vinod, what is your take home point from today's discussion?
My take home point will be, ARDS patient, look at the etiology. Do not delay intubation. If the patient is restless and patient may cause, PCL, so the patient may aspirate or some complication. So if you think the patient requires intubation, you should do an early intubation. And yes, so the management, we have already discussed a lot about the management of the ventilated patient.
Right. And Dr. Vivek, what is your take home message for today's audience?
So my take home message is please early recognize and please and early intervene the patient. So we can save the life of that patient, sir.
Right. Very nice. Dr. Stuti, what would you like to say? You have very beautifully elaborated all the concepts today. What is your take home message for today's audience?
Uh, so I think we should be treating the patient and not the disease. It's not like you are in a pulmo person, so you will only look at the lungs and forget everything else. As Kaladhar sir mentioned, there are n number of things that you need to see about the patient, and you have to even look at the from the attendant's point of view, because it's like a very big emotional burden from them. See, they're spending their time, they're spending the money. That is okay, but it's a very big emotional burden. Whether when we are discussing all these big things, they don't understand it. So for them, their only question is whether my patient will come out or not. So I think we need
Right.
to keep these things also in mind, sir.
Very relevant point, very humanitarian point. Now, Dr. Kaladhar sir, really it's been a pleasure to do a webinar with you as the panelist. I'm sorry I troubled you in a lot of questions
Yeah,
and took
no,
your
that's
opinion
absolutely fine.
while the other panelists also gave their opinion. But sir, it was very necessary because the practical aspects and the academic aspects, when they come together in practice, I think that is very important for the audience to know. So,
Yes,
sir,
yes.
what is your take-home message on ARDS management, sir? Please.
Yeah, it was really very, very good interaction with all of you, and especially very good moderation by Dr. Ravi Dosi sir, and very good interacting with Dr. Vivek, Dr. Vinod, and Stuti Gupta. So my final take home, I think most of them have illustrated. The thing, whatever
Thank you, sir.
we learned, has to be translated into the practical aspect. The simple thing, what we look at, suppose low tidal volume, it's not been very much practiced. So the theoretical things have to be bring towards the patient, like bedside. And even if you are looking at the ventilator, how low tidal volume being practiced, when you are increasing PEEP, how to look at the hemodynamics. So theoretical things should be put into the practical aspects, and they should be, the protocols should be stringent, and should be, I can say, you should be obsessed about whether really low tidal volume ventilation is not going. No, it has to go. That much obsession should be there. among you, if you are leading one ICU, probably among your team. So it's a team effort. The team has to continue the efforts as like probably the team leader or otherwise the senior, whoever is there. So it has to percolate downwards, and it has to be a continuum of care where every protocol has to be put in place, and this then it will translate into good outcomes.
Right, right. Very, very
Yeah.
beautifully told, sir. Really, it's been quite an enlightening talk that we have had with you. You have laid stress on points like teamwork, like Dr. Stuti has told that you should take about the emotional issues. Dr. Vivek and Dr. Vinod have also illustrated on several points that how we should totally look after that patient. Not only lungs, he has other body parts also. He has a family also. So take care of that. Most importantly, one thing which I would like to highlight is all my respected panelists kept on talking about trials, trials, and trials. You have to remember that ARDS is a highly heterogeneous disease, and even the most of studies, even the most highest of centers, base their knowledge on the basis of trials. So we should all try to publish our work, and research more, study more. And with this very positive and high academic note, I would like to thank CCI, thank the entire team of CCI webinar, the
Thank you, sir.
technical team which has supported us. I would like to thank team ALKEM for supporting in this academic webinar. And I would like to give a big thanks to audience who has joined us for listening to this very, very important webinar, which will be uploaded on the CCI YouTube channel in a few days. So me, Dr. Ravi Dosi, I would like to now wish all of you a very good night, and hope to see you next
Good night, all
Thursday
of you.
with
Yeah.
another.
Good night, sir. Thank you, sir. Good night,
Thank
sir.
you.
Thank you. Thanks.
Thank you,
Yeah.
sir.
Good night. Take care.